Yes, welcome.
The tech team, please, you stopped the recording. Can you please go live again?
Sorry. We are live now, ma'am.
Yeah, but you have stopped the recording. Just check accordingly.
It was recording in my laptop, ma'am. I have stopped it, and now I have done the live. It
Yeah,
is on
sure.
YouTube. Okay.
Sure. Can we please share the slides first? A very good evening to all the esteemed faculty members and the delegates who have joined us today for the 235th episode of the Happy Learning Masterclass. Today, we have a special focus on amniotic fluid, and today's episode is in association with Karimnagar, Khammam, Mehboob Nalgonda, Nizamabad, and Warangal societies, with a special thank you to Radha Lakshmi Madam. This webinar is the brainchild of none other than Dr. M.C. Patel, sir, who is the program director and convener of these series since the time of COVID. Let us evoke the blessings of Lord Almighty, and after that, we can start with our webinar. We can't hear you. There is no audio. The tech team, please look into the matter. It is my proud privilege to introduce none other than Dr. M.C. Patel, sir, who has also been the past vice president of FOXY, the past president of IMA Ahmedabad, the past president of NMO, the past president of the Ahmedabad OBGYN Society, an active social worker who has been working in the northeastern district since the last 33 years as free camps every year. Sir is a visionary who had started these academic programs in the time of COVID because learning had become difficult. But he has been persistent and being the perfect two core, we've reached 235th episode today. Sir, we welcome you and we request you to please give your welcome address.
Thank you, Dr. Monica. It gives me immense pleasure to welcome you all to this 235th episode of Happy Learning Masterclass web series. And today joining society, Karimnagar, Khammam, Mahbubnagar, Nalgonda, Nizamabad, and Warangal. I welcome three guests of honor, Dr. Narasimha Reddy, Dr. Achanta Vivekananda, and Dr. Sandhya Rani Madam. They have kindly consented to be guest of honor to bless the webinar. They all are with us always. Whenever I have asked them to be with me in any of my academic activity, they had been always there. So welcome all of you, and thank you for sparing time to bless this webinar. I also welcome learned chairperson Dr. Anusa Reddy Madam from Warangal, Dr. Madhuchandar from Warangal, Dr. Rajeshwari Madam from Nalgonda. They are going to chair a very important session of polyhydramnios, which is to be delivered by Dr. Sravanti Madam from Karimnagar. I also welcome one more set of chairperson, Dr. Manjula Rapolu Madam from Nalgonda, Dr. Ashok Kumar from Siddipet, and Dr. G. Mayuri from Mahbubnagar. And they are going to chair one more important session about oligohydramnios, which is to be covered by Dr. Geeta Lokam Madam from Khammam. I also welcome one more set of chairperson, Dr. Lakshmi Ranuka from Mahbubnagar, Dr. Padmalata from Karimnagar, and Dr. Lakshmi Padmapriya from Mahbubnagar, and they are going to chair session about legal issues in amniotic fluid embolism, and which will be delivered by me only. One more set of chairperson, Dr. Vishnu Priya Reddy Madam from Mahbubnagar, Dr. Malleswari Nukka Madam from Nizamabad, and Dr. Swidhi Anup from Korulata. And they are going to chair one more important session about amniocentesis and genetics, and it is to be delivered by Dr. Anuradha Madam. And I also welcome my own team, Dr. Monica Omardan. She is convener for this series since long from Solapur, Dr. Monica Gupta from Alwar, Dr. Deepika Lugani from Delhi, Dr. Nivedita Datta from Bokaro, Dr. Satabdi Day from Siliguri, and Dr. Megha from Kalaburgi. They all are coordinators in this series. And I put it on record my special thanks to Dr. Radha Lakshmi. He has helped me a lot as far as this episode is concerned, not only designing but up to execution of this webinar. Thank you, Radha Lakshmi.
Thank you, sir.
And all the best for your future endeavor about your Foxy chairperson election. I know you are a very hardworking person, very deserving fellow, and I request all the learned president and secretary of respective society who are her voter, you have to vote for her. And at the same time, there will be nomination in month of May, most probably from 7th, it will be starting. And this time it is e-voting, e-nomination. So you have to go with e-nomination. And with this, when this series I started in era of COVID-19, my intention was to just meet our Foxian friends on screen to say hello. And because at that time, physical meetings were not possible. And we were discussing focus topics. Say, for example, just we have selected today's topic, amniotic fluid, not too much, not too less. That way we were discussing focus topic. And ultimate goal was to brush up our knowledge and to be helpful to our Foxian friends in their day-to-day practice, but at the ultimate goal was to check maternal mortality, maternal morbidity, and infant mortality and morbidity. Because Government of India and WHO has given us a target by 2030, maternal mortality rate should be less than 70 and infant mortality rate should be less than 12. And it is possible only if we go join hand with organization like Foxy, IMA, government, and other organizations, and particularly with our obstetrician friends who are working in remote rural India. And if we take care of our patients since beginning, if we pick up high risk pregnancy cases well in time, and if we refer them to appropriate place well in time, then it is possible to check maternal mortality. And with this aim, we are discussing focus topic, and still we have continued this series. When I started, 3 more people joined me. Now I am happy to announce this Happy Learning Masterclass family is more than 8,000 people, 8,000 Foxian friends and people from other than Foxy also. So with this remark, welcoming you all the president and secretary of joining society who have joined this webinar, Karimnagar, Khammam, Mahbubnagar, Nalgonda, Nizamabad, and Warangal, and all the delegates. Thank you very much.
Thank you,
Thank
Dr.
you, sir.
MC Patel, sir. It's a great work you are doing.
Thank you, madam.
235th series means it's not a joke, sir. You are like teaching so many gynecologists in legal problems, so different topics. It's very happy, sir. And sir is, we all know about sir, MC Patel, sir. So like sir is contesting for president election 2026, candidate for Foxy president election 2026. So, sir, advanced congratulations. Very happy. Thank you,
Thank
sir,
you, madam.
for giving this opportunity. And also, Dr. Radha Lakshmi from Karnool, she is a professor and a department of OBGYN and also secretary OBGYN Society. Madam, you are also very hardworking lady. And all the best contesting for chairperson for the medical legal committee. Thank you. All the best. Thank you, everyone.
Dr. Radha Lakshmi is following me because I was chairperson of the same committee,
Same committee, sir.
committee Foxy, long back in 2011. So I'll be happy if Radha Lakshmi joins my club of Ethics and Medical Legal Committee Foxy. Thank you.
Thank
Thank you, sir.
sir.
I need your blessings, sir.
Yes.
Thank you, sir. We wish both of you all the very best for all your future endeavors, and I request all the joining societies to please nominate both of them, because this process this time will be e-voting. So in case if you have any problems regarding the nomination and e-voting, you can get to any of us, and then we will be able to help you with that. But request you to please nominate, because the nomination process has been made very, very easy this time. So moving forward, I would request Dr. Monica Gupta, madam, to please introduce our guest of honor for today. Monica,
Thank you,
ma'am?
MC Patel,
Yes,
sir. Thank you, MC Patel, sir, and Dr. Monica for giving me opportunity. And sir is sir is a person, idol person for all of us, because how hardworking he is, and we should take some inspiration from him. He has done so many webinars, and we all should follow his footsteps, and we will definitely achieve a great height as the sir has achieved, and he will be on the supreme post of the Foxy one day, and we will be following him through his footsteps. Thank you, sir. And today's our guest of honor is Dr. Narasimha Reddy, sir, Dr. Achanta Vivekananda, sir, and Dr. Sandhya Rani Burri, madam. Please put the CV of Dr. Narasimha Reddy, sir. Dr. Narasimha Reddy, sir, is a past president of Warangal Telangana OBCY Society. Please put the CV. And he is a very senior obstetrician, and he is working in the Warangal, and he is a pioneer in many of the works in the field of OBGY. Over to you, sir, for your kind blessings.
Very good evening, everybody. At the outset, I would like to thank the MC Patel, sir. At the same time, I hope all of our society members are going to nominate you, sir. Definitely, I will say that all the societies in Telangana will nominate you and Radha Lakshmi for the
Thank you, sir.
upcoming elections, sir.
Yes, sir.
So I can give you an assurance that 10% of our societies are going to be with you, sir.
Thank you.
So
Thank
I
you.
don't want to take much of your time, sir.
Thank
Only
you,
I
sir.
think, I thank Radha Lakshmi Garu for choosing excellent
Thank you,
topics.
sir. Thank you.
Because, though I'm a senior gynecologist practicing for the past 35 years, still I have doubts, how to manage all the things, polyhydramnias, oligoamnias, and so on and so forth. Of course, sir's topic is going to be a highlight. And Madam Janet, Anuradha Garu is an excellent speaker. I think we can learn a lot from her. Thank you very much for inviting me, making me a part of your webinar, sir. Thank you, sir.
Thank you, Narasimha sir. You are always with me. Whenever I have called you, you stood with me. So thank you for sparing time to bless us.
Thank you, sir. Thank you, sir.
Welcome.
All
Thank
the
you,
best,
sir,
sir.
for your words of wisdom. We look forward for your support in the future. The next guest of honor is Dr. Achanta Vivekananda, sir. He's a past president of Warangal OBGY Society. He's a dean professor, HOD in PIMS Institute, and he's a publisher of Perspective in Medical Research and Indexed Journal of PIMS, and he's doing a lot of work on HIV and AIDS, and he has founded and chair of the Center of Excellence for Sickle Cell Thalassemia and Genetic Blood Disorder at PIMS, and he's a member of Justosis India. the dystosis score given by the committee for the detection of PIH in the pregnancy. Over to you, sir, for your word of wisdom.
Namaste, Dr. Patel, sir.
Yes, namaste.
Namaste, and Dr. Radha Lakshmi, namaste.
Namaste, sir.
Organizers for today's program. It's a great initiative by Dr. M. Sir, which I think I know him since the last 2 decades. And I still remember fond memories of his AICOG on the Republic Day when I had the privilege for CG Saraya CME. Thank you, sir, for the great hospitality.
Yes.
On this great occasion, I should really appreciate your service, what you are doing, and your camps in the Northeast region, the areas where nobody dreads to go. So really, my pranams to you and your team for this outstanding work in conducting these camps in the Northeast region, and your vision for the future. And your this is the 235th program, as you are saying, that is really great, conducting this digital CMEs across the country involving all the practicing obstetricians. And on this occasion, I wish you all the best to be elected as the FOGSI president for the next year, this year. And I assure you that I will confirm and canvass for you for this, for our members and my other colleagues in Karimnagar and adjoining societies, to see that you are elected with a good majority. And also good wishes to Dr. Radha Lakshmi for the chairperson of the Medical Legal Committee. And I thank organizers for giving me this opportunity to chair this very important session on amniotic fluid. Thank you once again, and wish you all the best.
Thank you. Thank you, Achanta sir, for sparing time to bless us. You are always with me. Whenever I have called for any of my academic activity, you have always say, yes, I am there. Thank you, sir.
Thank you for your kind words, sir. Our next chief guest of honor is Sandhya Rani Burri ma'am. Please put her CV. And she is a past General Secretary of Warangal OBGY Society, HOD for DNP Institute at Lakshmi Narsimha Hospital, Chief Consultant over there, Director at Akshila Hospital. She is a IMS practitioner and she is a member of so many societies. She has published national and international papers in the journals and conducted many conferences, PMEs at Warangal, and was speaker in many national and international conferences. Madam, if you want to add few words of blessings.
She's muted, Monica.
She has already given the blessings. If she wants to add some, I think she was in an emergency, so she gave her words of wisdom before. So, okay. Sir, should we proceed for the academic program?
Oh yes.
Over to you, Deepika, for the academic program. And before that, I request everyone to please vote and support for Dr. MC Patel, sir, and Radha Lakshmi, ma'am.
Thank you.
Monica ma'am, there's a slight change. This time, Dr. Radha Lakshmi madam would be conducting the first session.
Okay.
Yeah. Thank you.
Over to you, Dr. Radha Lakshmi.
Yeah, it is my proud privilege to introduce the chairpersons of first talk, that is Dr. Anusha Reddy. Anusha Reddy, CV, please. She is the Secretary of Warangal OBG Society and Deputy Medical Director, 49 Telangana, General Secretary, Warangal OBG Society. She did her PG from Kamineni and SVS Medical College, and she is the former Assistant Professor at Government Maternity Hospital, Hanmakonda. She got many awards, and she is the author of book of Fertility Synopsis. And welcome, Dr. Anusha.
Thank you, ma'am. Thank you.
And I want to introduce our next chair, Dr. Madhuchandar.
So can I call you back after?
He is the past president of Warangal Obstetrics and Gynec Society. He did certificate in infertility, Milan. Professor of OBG, SIM, SRC, retired assistant professor, KMC Warangal, and consultant at GVEC Hospital. Sir, are you there? Madhuchandar, sir? Okay. Next chairperson. She Rajeshwari Praveen. She is my good friend, and she is the present secretary of Nalgonda OBG Society, Director and Consultant Obstetrician Gynecologist, Rajeshwari Hospital, Nalgonda, Honorary Secretary, Nalgonda OBG Society. And her areas of interest is high-risk pregnancy, infertility, and women's health education and cancer prevention. She did many services, and she is the past treasurer of IMA Nalgonda and past vice president IMA Nalgonda and professor of OBG. And welcome, Dr. Rajeshwari. And I request one of the chairperson to introduce our first speaker, Dr. Shravanti.
Hello, everyone. A very good evening. This is Dr. Anusha Reddy, General Secretary, Warangal Walks, and I thank you, the organizing committee, for including me in this webinar. Moving to the first section, polyhydramnios, a condition that can quietly complicate pregnancy, yet with timely diagnosis and expert care, outcomes can be greatly improved. To guide us through this topic, we have with us Dr. A.S.L. Shravanti, an experienced obstetric gynecologist and infertility specialist with over 15 years of clinical experience. She has specialized in high-risk pregnancy, advanced gynae care. She is also trained in emergency neonatal resuscitation and service, and she served as chairman of Soumya Multispecialty Hospital and Infertility Center. Currently, she holds the position of Foxy General Secretary, Karimnagar. And let's hear from Dr. Shravanti as she breaks down polyhydramnios, its causes, risks, and management in a simple and practical way. Over to you, ma'am.
Shravanti? Yeah. Shravanti, you are muted. Muted, Shravanti.
Hello, good evening, everyone. So thank you for giving me this opportunity. Actually, can anyone help me with sharing this PPT? This is
Bhavana. Bhavana, are you there?
Ma'am, one of the coordinators can actually share the presentation. It will be easier that way. I have made the co-host.
so can I send my PPT to your number, Bhavana?
Yeah.
Whom should I send then, ma'am? Radha ma'am, can I send it to you?
No, it is not possible in my iPad. So send it to Patel, sir.
MC, sir?
No,
Yeah.
but I have to manage as far as her presentation is concerned.
Yes, sir.
Okay.
Send it to Patel, sir. Bhavana?
Okay, ma'am.
So she's sending in WhatsApp.
No, Bhavana is sending it to you, sir.
Okay.
Shravanti ma'am, you can send it to me once on my WhatsApp and then I will share.
But any of coordinator may do if you send.
Have you sent, Shravanti? You can
Yes.
send directly to Patel, sir.
Madam, can any other person continue with the presentation, madam? So it was loading and it was been in the process of sharing to Bhavana.
Okay. So can we go with the second speaker?
Yes, madam. Continue with the second speaker. Meanwhile, I'll send this.
Shravanti ma'am, meanwhile, you can try to grab a laptop around you so
Yes,
that
actually
it will be
I
easy.
have taken, but this is not actually I have all the PPT is already received by Bhavana, madam, just now. Okay, if she opens, then I can continue with the presentation.
Okay.
I also have to download it first and then share it to MC, sir.
No. You can't share it directly, Bhavana?
No, ma'am. It's downloading and then I have to send it
But
to Ansu,
is
sir.
there any problem for a speaker to operate by her own this presentation?
Yes, ma'am. Yes, sir. So there is some technical issue. My presentation is not opening in
Okay.
this
No issue.
platform.
No issues, ma'am.
Yeah.
Monica, any of our coordinator can also do.
Ma'am, if you could send the presentation across, we can help you with that, ma'am.
Yes, yes.
You put it in the group, Shravanti.
Okay, madam. I'm sending now in the group. Yes, madam. I have sent it.
Yeah, Bhavna, can you share it from your side, please, now? You have received the CV.
It is in the group.
Presentation.
Monica, it is in the group.
Yes, ma'am.
Bhavana?
Ma'am, even I can't share it from my end. There's some problem.
There is some problem. You're right. I am also trying, but
Okay, Shravanti, you read it out.
Okay, shall I explain it like audio?
Okay. No problem.
Okay, madam.
Hmm.
So today my topic is about polyhydramnios, and polyhydramnios is defined as an excess accumulation of amniotic fluid during pregnancy, diagnosed in the ultrasound by using two methods, that is by single deep pocket and also amniotic fluid index. If the single deep pocket is more than 8 centimeters, it is called polyhydramnios, or the complete overall amniotic fluid index is more than 24 centimeters. It is also known as polyhydramnios. We also know that the physiology of the amniotic fluid has a chain of processes that is happening in the womb. That is like first starts with the fetal urination, and then it eventually causes the fetal swallowing, and then which leads to lung fluid secretion and also intramembranous absorption. So when this cycle goes on smoothly, the adequate amount of amniotic fluid will be circulated, which doesn't cause any poly or oligohydramnios. So what is the etiology of polyhydramnios is the causes are like maternal, fetal, and idiopathic. So now we can see the slides also, madam. So the next slide is the maternal. Maternal, it is the diabetes mellitus is the most common factor we come across, and RH isoimmunization and hydrops fetalis, and fetal anomalies like GI anomalies like esophageal and duodenal atresia, CNS anomalies like anencephaly, and neuromuscular disorders and multiple gestation are the common fetal causes for polyhydramnios. There are also some idiopathic causes where we cannot evaluate the cause. So we have to think about any other abnormalities. And coming to the pathophysiology, here there is decreased fetal swallowing. That is the GI and the CNS anomalies will reduce the absorption. and also impaired reabsorption like placental or intramembranous dysfunction will limit the absorption, and also increased fetal and urine balance, which is commonly seen in maternal diabetes or fetal anemia like conditions. So next slide. So the coming to the classification. So classification, it is classified into mild, moderate and severe, where in the mild polyhydramnios, we see the amniotic fluid index from 25 to 29.9 or 30 approximately, and the single deep pocket is 8 to 10 centimeters. And moderate polyhydramnios, the amniotic fluid index is 30 to 34, where single deep pocket is 10 to 12. Where severe polyhydramnios, the AFI is more than 35 centimeters and single deep pocket will be 12 centimeters. So what are the clinical features we come across in polyhydramnios is symptoms like abdominal discomfort, distension, breathlessness, because the breathlessness mainly because of diaphragmatic pressure, pedal edema, varicose veins, difficulty in walking and low back pain. And also on examination, we can find the uterus is very large for dates, and also fluid will be positive, and we can also see the shifting dullness, and fetal parts are very difficult to palpate because of polyhydramnios, and fetal heart sounds are muffled because of the resistance caused by the excessive fluid. And how can we diagnose polyhydramnios? Is by ultrasound, that is the AFI method. Some of the deepest vertical pocket in each of the 4 uterine quadrants will be taken. Next slide, please. So here the normal will be 8 to 24 centimeters or more than 24 centimeters in polyhydramnios, where single deep pocket method is also seen, where the single largest fluid pocket is more than 8 centimeters, preferred in twin pregnancy usually. And anomaly scan, the targeted ultrasound to identify the fetal structural anomalies, example like gut obstruction, neural tubal defects, cardiac defects. These are all should be done to diagnose the polyhydramnios. Next slide. And coming to the differential diagnosis, we also confuse polyhydramnios with so many other disorders like multiple pregnancy, macrosomia, uterine fibroids, ovarian cysts, wrong dates, molar pregnancy, etc. So we have to do specific investigations to rule out all the other differential diagnoses. Like we can differentiate polyhydramnios with multiple pregnancies by ultrasound, and we can also differentiate between big ovarian cysts or fibroids by again ultrasound and other scan findings. We can differentiate macrosomia with the BPD, biparietal diameter and acromial circumference in ultrasound. And also wrong dates is the most common mistake done by the doctor or the patient when taking the history, and we have to correlate with the ultrasound always so that the wrong dates can be actually we can bypass that problem. And next slides, complications. So coming to the complications, we do have so many complications pertaining to maternal and fetal issues. Like maternal complications are preterm labor, premature rupture of membranes, placental abruption, postpartum hemorrhage, malpresentation, cord prolapse, and operative surgeries. Fetal complications like preterm birth, perinatal asphyxia, umbilical cord prolapse, fetal malpositions, intrauterine fetal demise, and structural anomalies related morbidities are usually seen as complications related to fetus. Next slide. And next slide, the next slide. Associated fetal anomalies were clearly seen in this diagram. Like we also, as I already told about the CNS anomalies like anencephaly, spina bifida, and GI tract abnormalities like esophageal atresia, duodenal atresia, diaphragmatic hernia, cardiovascular issues, neuromuscular and chromosomal things also are clearly depicted in this diagram. Next slide. So what are all the investigations we have to do related to polyhydramnios is the fetal anomaly survey, that is AFI and single deep pocket, and fetal biometry, Doppler, and also biophysical profile. What are the invasive testings? Are amniocentesis for karyotyping, like trisomy 13, 18, 21 should be done. And we have to offer all the anomaly related detection scans for the patient. Next slide. And maternal blood tests like blood glucose, GTT has to be done, complete blood picture, blood group, and RH indirect Coombs test to rule out RH isoimmunization, where we can see amniotic fluid altered index, and also torch screening should be done. And invasive testings like amniocentesis for karyotyping, I already told about that. And the fetal surveillance like non-stress test has to be done continuously to monitor the well-being of the baby. Next slide. So coming to the management, the delivery has to be planned cautiously. The timing of the delivery, mode of the delivery, and the team has to be ready to avoid fetal distress or postpartum hemorrhage-like conditions. And amnio reduction should be done for severe and symptomatic patients. And for mild and moderate, expectant management will be sufficient for them. Next slide. So for the management related to mild and severe, we have to take care of all the underlying causes of polyhydramnios like glycemic control and serial ultrasounds and BP biophysical profile of the baby has to be done. And hospital admission is required for symptomatic patients. Amnio reduction, as I already told you. Endomethacin can be given below 32 weeks, and corticosteroids has to be given anticipating for preterm delivery. And weekly surveillance should be done, and planning for early delivery if the condition is worsening. Next slide. So here, next slide. And in this slide, I'm telling that what is the role of amnio reduction. So usually amnio reduction is the therapeutic removal of excessive amniotic fluid under ultrasound guidance. The technique is usually done with the patients where there is severe discomfort, respiratory compromise, and preterm labor, and AFI is more than 35 centimeters. Usually 1 to 1.5 liters per session can be taken out using an 18 gauge needle and under continuous ultrasound guidance. Next slide. Complications like PROM, preterm labor, and placental abruption, infection, and fetal injury are usually taken as concerns from the patients during this amnio reduction process. Next slide. And again, the next slide. So here, role of indomethacin is also very important, which is a non-selective COX inhibitor, where prostaglandin, it is a prostaglandin synthetase inhibitor, which reduces the fetal renal blood flows further. So it eventually decreases the fetal urine output. It also enhances the fluid resorption across the fetal membranes and can reduce AFI by 40 to 50% within 1 to 2 weeks of duration. So 25 mg oral indomethacin is given 6th hourly, and we have to monitor fetal renal function and ductus arteriosus by weekly Doppler when giving indomethacin. Next slide. Next slide. So monitoring and follow-up is the most important part of polyhydramnios, where detailed anomaly scan has to be done, and every week non-stress test and assess the maternal symptoms, and we have to check for any preterm contractions. And if any problem is there, we have to be very cautious and plan the delivery by a senior most obstetrician, because delivery and also post-delivery postpartum hemorrhages and malpresentations are very common in polyhydramnios cases. NICU team also has to be very alert, and we have to, if the patient is on indomethacin, we have to monitor the ductus arteriosus by Doppler weekly. Next slide. So during the labor, there should be controlled amniotomy should be done, slowly draining the fluid with needle or amnio hook to prevent sudden decompression and cord prolapse. And we have to check for the fetal presentation before and also immediately after amniotomy. And unstable lie is a relative contraindication of vaginal delivery. So we have to shift the patient immediately for an emergency LSCS. And we have to watch for the cord prolapse. And after rupture of membranes, immediately we have to confirm the fetal heart rate and perform the vaginal examination. Active management of third stage labor by giving uterotonics like Syntocinon on IV route has to be given. And the neonatal team should be on standby for resuscitation and evaluation of fetal anomalies. Next slide. Next slide. So here is the prognosis of polyhydramnios, where 50 to 60% is idiopathic and 25% is the anomaly rate, and 10 to 15% will be the chromosomal abnormalities found in polyhydramnios. Next slide. So first we have to confirm the polyhydramnios and then check the etiology. And also if the etiology of GDM-like conditions are happening, then we have to control by glycemic index. And by 32 weeks, we have to tell the benefits and risk factors of indomethacin, and we have to start and then monitor continuously till delivery, and teamwork should be there during the delivery time. Next slide. So these are the take-home messages of polyhydramnios. So AFI has to be clearly diagnosed, and think that patient is symptomatically good, or she is suffering with any problems, and we have to rule out the etiology. And management by severity, we have to divide the patient pertaining to the severity into mild, moderate, and severe cases, and the labor has to be vigilantly undertaken. So these are the take-home points for all the graduates. As I already told you, all these points are already covered. Thank you, madam, for giving me this opportunity. Thanks a lot.
Thank you, Dr. Shravanti. I would request the chairpersons to please give their inputs for this session on polyhydramnios.
Hello.
Madam, excellent presentation.
Thank you.
Especially your slides are very enthusiastic and presentation.
Thank you.
Very nicely presented. And may I know, madam, what is your experience about the indomethacin? What is your experience?
In my practice, I have given two patients, sir, indomethacin during one patient during my post-graduation period, and one patient in my practice time. So both have done well, sir, and till delivery they have not experienced any complications with indomethacin.
Okay. Thank you, madam. Thank you.
Thank you, sir.
Yeah, thank you, Dr. Shravanti. Yeah.
Thank you,
Yes,
Radha madam,
moving
for
on.
the opportunity. Thank you.
Yeah,
Thank
thank
you,
you, Dr.
thank you.
Shravanti, for that clear and insightful presentation. You have comprehensively covered the etiology, diagnostic approach, and management strategies. Very good. Thank you. I would like to thank MC Patel sir and Radha madam for me giving this opportunity, and all the best for both of you for your future endeavors. Thank you.
Yeah. Thank you, Anusha and Rajeshwari, Madhuchandar sir, for your chairing the first session. And thank you so much, Shravanti. You did a great work.
Thank you, madam. Thank you.
Thank you,
Chairperson.
Yes.
Yeah, and Shravanti ma'am, thank you for the talk. I request Dr. Nivedita Datta ma'am to please conduct the next session.
Thank you, Dr. Monica. And moving on to the second session, we're moving on from more to less. That is from polyhydramnios to oligohydramnios. And to chair this session, we have with us Dr. R. Manjula Raghunandan. She is the president, Nalgonda, since 2024. She is the medical director and senior consultant of Sri Srinivas Nursing Home with special interest in adolescent health, anemia, high-risk pregnancy, cancer prevention, and menopause. The next chairperson for this series, Dr. Ashok Kumar Sir, is the founder president of Siddipet Obs and Gynae Society, a senior consultant of Siddipet now, a member World Association of Laparoscopic Surgery and member of IAGE, and obviously with special interest in laparoscopy and with years of experience in Obs and Gynae. The third chairperson for the series, Dr. Mayuri, is the president of Mahabub Nagar Obs and Gynae Society, another senior doctor with years of
Can I
experience.
request the tech team to please put the CV slides and stop sharing this PPT, please?
Anyway, I've spoken the CV, so we can have any of the chairpersons to please introduce the speaker, Professor Geeta Lokam.
Yeah, we will need her slide at least, ma'am.
Please put the CV first, chairperson.
Okay,
Please put Dr. Geeta's slide. The tech team.
Chairperson's slides followed by
Okay,
speaker.
okay. I'm not able to stop this, madam.
No, that's okay. If required, I'll speak about Dr. Geeta, and then the chairpersons can give their inputs. If anybody of the chairpersons would like to add, then it's okay. Dr. Geeta Lokam,
Yes.
she's the secretary, Kaman Society, and she's the professor at Mamta Medical College. So, Dr. Geeta, I think you can go with your slides because they're unable to stop sharing.
Where to click, madam? Stop
Yeah.
sharing. Zoom. Minus and plus.
Tech team, I'm Dr.
Bottom
Are these
right
Dr.
corner.
Sir,
These are
Ashok
Dr.
sir, are you there, sir?
Yeah,
Excuse
madam.
me.
Bottom right.
Yeah, madam, I'm here. Yeah.
Okay.
Good evening, everybody.
Sir, you were. I request you to give the concluding remarks, sir, because
Sure,
they are
madam.
not able to.
Sure, madam.
Minus. Yeah.
Mayuri madam, are you there? Mayuri madam? Not there.
Zoom out.
Manjula.
Can I request Dr. Geeta madam to please start her talk?
How, madam?
Yeah.
Okay. Shall I stop the sharing?
No, ma'am, you can please continue with your talk.
Okay, ma'am. I'll continue.
You start.
Good evening, all the members, ma'am. Today my talk is regarding the oligohydramnios. So in this topic, we are going to deal with the following contents. The first and foremost is how the amniotic fluid actually it is produced, and the normal amniotic fluid according to the different gestational age, and the definition and etiology and management and diagnosis and management. And first, coming to the physiology of the amniotic fluid, how the amniotic fluid is produced. The amniotic fluid usually around the 10 weeks of the gestation, it approximates around approximately 40 ml, and it gradually increases from the gestational age up to the 20 weeks. It comes around 400 ml. And the peak of the amniotic fluid we can see around from the graph, it is showing around 34 to 36 weeks of gestational age, amounting to about 800 to 1 liter. Following 36 weeks of the gestational age, the amniotic fluid usually gradually declines. We can see from the graph. Around 40 weeks, it comes around the 600 ml. From the 40 weeks of the onwards, the graph is showing gradually decline. It declines at about 8% per 1 week, amounting about 125 ml. So this graph, it shows the importance of the post-term pregnancy, where the amniotic fluid beyond the 40 weeks of the gestational age gradually reduces. And coming to the next, how this amniotic fluid is produced. According to the trimester, how this amniotic fluid produced is from the first trimester up to the end of the first trimester, the amniotic fluid mainly is the transudate of the maternal plasma. Means it is almost from the maternal plasma, it transmits from the amnion. That type of transport, it is known as the transmembranous transport. And from the mid of the first trimester up to the starting of the second trimester, usually the amniotic fluid production also comes from the fetal circulation. And the second is, that is from the second trimester onwards, mainly the fetal kidneys takes over the amniotic fluid. So the first trimester amounts only the maternal plasma and from the fetal skin. That is the non-keratinized fetal skin. From the 20 weeks, usually the kidneys take over the function. So hence any renal anomalies we have to look after, especially if there is oligohydramnios from the second trimester. So The fetal urine, usually the output at the term is about 400 to 1 liter. And along with the fetal urine also, the fetal lung secretions also adds up to the amniotic fluid. So this is the production according to the trimester, that is the first trimester from the second trimester. And removal, how this amniotic fluid gets reabsorbed is mainly from the fetal swallowing reflex. Usually it swallows 400 to 800 ml of the liquor every day. So here the GI system plays a main role in the removal of the amniotic fluid. And this is the table that is showing the schematic representation, that is how the amniotic fluid is produced from the other sources. That is, the first is the maternal circulation, the fetal skin, fetal urine, everything, and how it is transported. And this is showing the amniotic fluid gradually increasing from the gestational age up to the 40 weeks of gestation. And how we should define the amniotic fluid. There are so many definitions, that is how we define the oligohydramnios. The first one is the amniotic fluid volume if it is the less than 5th percentile for the gestational age. And another definition is if we take the amniotic fluid index, it is less than 5. And if we take a single vertical pocket, it is less than 2 centimeters, which corresponds to the less than 3rd percentile. And coming to the incidence, it accounts about 0.5 to 5%. And the etiology. So coming to the etiology, we can divide again into the maternal, fetal, placental, and the idiopathic components and the drugs. Coming to the maternal, the main etiology being the preeclampsia, Eppler syndromes, and the chronic hypertensions. And the fetal is the main cause is the rupture of the membranes, and the chromosomal anomalies also we have to rule out. And any congenital anomalies, especially the renal anomalies, that is the polycystic kidney diseases, multicystic kidneys, or any bladder outlet obstructions, we have to rule out. And any growth restricted fetus also leads to the oligohydramnios or any unexplained fetal deaths and the postterm pregnancy. And the next cause, coming to the placental causes, if there is any hematomas or the chronic abruptions in the placenta also leads to the oligohydramnios, that is known as the CAOS, that is the chronic abruption oligohydramnios syndrome. And the next important cause is we have to rule out the twin-twin transfusion syndromes. And especially the drug history also we have to take. The usage of any ACE inhibitors, that is the captopril or the enalapril, also reduces the amniotic fluid, and angioreceptin receptor blockers and the prostaglandin synthetase inhibitors. And the next classification is after ruling out all these causes, that is the maternal cause, fetal cause, the placental, and the drugs, the next comes under the idiopathy. And how we have to diagnose the amniotic, that is the oligohydramnios. So usually the diagnosis, first we have to start from the symptomatic. That is, suppose if you see the symptoms, some patients may not have any specific symptoms. Some patients, they may give the history of the leaking per vagina. And some patients, they give the history of the crossed dates, that is the postterm pregnancy. And history suggests of the preeclampsia. Usage of any drugs, what we have discussed, that is the ACE inhibitors, angiotensin receptor blockers, and the prostaglandin synthetase inhibitors. And some women, they may pursue the less fetal movements. These are the history. And coming to the signs, what signs we can observe in the oligohydramnios is, first thing is when we are palpating the symphysiofundal height, it is less than the period of the gestational age. That is, the uterus will be the small for the date, and we will feel the fetus will be full. And sometimes we can see the signs of the growth restriction and the absence of the fetal heart rate. And coming to the next important one, that is the ultrasonography. In the ultrasound, how we can diagnose the oligohydramnios is there are two methods. That is, the first one is the calculation by the mean vertical, that is a single deep vertical pocket, and the next one is the amniotic fluid index. The single deep vertical pocket, if it is less than 2 centimeters, we can call it as a oligohydramnios. If it is less than 1, we can call it as a severe. And the amniotic fluid index, that is the less than 5 centimeters. We have to divide the abdomen into the 4 quadrants by keeping the our probe that is at the perpendicular to the maternal abdomen. And we have to take the maximum vertical pocket in the 4 quadrants. So if it is amounting to the less than 5, we call it as the oligohydramnios. So here in our clinical practice, we usually take the single deep vertical pocket and the amniotic fluid index. But if we take the amniotic fluid index, usually the more of the antenatal women will come under the oligohydramnios. But there won't be any difference in the neonatal outcomes. Either of it we can take. But especially in that means we usually use more the single deep vertical pocket measurements. Coming to the next one, that is the what are the complications that make us worry regarding the oligohydramnios? That's first one is the abortions. Because if any anomalies are there, we have to terminate the pregnancy and the preterm delivery and intrauterine, because the oligohydramnios, it will lead to the growth restrictions and the intrauterine fetal deaths, any deformities of the fetus, that is the contractures. As the amniotic fluid is very important for the lung development, it might lead to the pulmonary hypoplasia and the malpresentations and the fetal distress and the meconium aspiration syndrome, which might lead to the low Apgar scores and the neonatal admissions. And what are the maternal complications we might expect is the increased morbidity, because we have to go for increased operative interference and the prolonged labor and the uterine inertia during the labor. And this is the deformities that we can expect in the oligohydramnios. Okay, so next, how we have to manage if we have diagnosed the oligohydramnios. It first depends upon our etiology, gestational age, and the severity of the oligohydramnios, and we have to see for the fetal status and the well-being. So how we have to determine the etiology is we have to rule out the that is the rupture of the membranes, and we have to rule out any medical illness, especially the preeclampsia complicating with the oligohydramnios, and we have to rule out all the anomalies, especially in the second trimester by the targeted, that is the anomaly scan. And we have to rule out the growth restriction and the intrauterine fetal death, and we are suspecting the etiology. And the amniocentesis, if we suspect any chromosomal abnormalities, and any Apla syndrome if we suspect. And how we have to manage if there is oligohydramnios. Suppose if we diagnose the oligohydramnios in the early pregnancy, that is especially in the first trimester and the second trimester, the most important, we have to rule out the congenital abnormalities and the chromosomal abnormalities. If the abnormalities are not compatible, we have to go for the termination of the pregnancy. And suppose if we have diagnosed the oligohydramnios after the mid-trimester, we have to see according to the gestational age dependent. Suppose if there are no any abnormalities, like especially the renal abnormalities and no leaking per the vaginum, we can manage the expectantly with the corticosteroids and the antibiotics if necessary. And the oligohydramnios at the term we can manage for, first thing is we have to evaluate for the rupture of the membranes, and we have to go for the test for the fetal well-being, that is the non-stress test. And we have to rule out any medical disorders and ultrasonography to rule out the fetal growth restriction. And if there are no any abnormalities, we can wait until 37 to 38 weeks of the gestational age. If there is any abnormality in the what we have discussed in the fetal well-being test, we can induce the labor. And suppose if you are managing the conservatively, because if you are not seeing any abnormalities in the fetal well-being, we have to advise the woman regarding the adequate rest, and the oral hydration or the IV hydration is very important. And we have to monitor the serial ultrasonography for the fetal growth, amniotic fluid index, and the biophysical profile scoring and the NST. And finally, we have to go with the induction of the labor or the cesarean section depending upon the pelvic assessment. And the note on the amnio infusion. Actually, I have not done any time this amnio infusion. I have read in the textbooks, but seniors, sirs and the madams, I need an advice actually after the session regarding the amnio infusion. This is a procedure where that is given usually the intrapartum. That is, we have to keep the intrauterine pressure monitor, and we have to infuse the normal saline. That is to reduce mainly the role of the amnio infusion is to reduce the fetal, that is the cord compression, and to dilute the meconium, so that we can improve the neonatal outcomes, especially in the case of the oligohydramnios. And finally is the take home message is, the first thing is, if we are seeing from the history, the woman is antenatal woman is using any drugs that might cause the oligohydramnios, we have to omit the drugs. And if there is any rupture of the
Yeah. Yeah. There may be some internet connectivity problem.
So in the meantime, the chairpersons can please give their comments till ma'am joins back.
Ashok sir?
Yes, madam. Dr. Geeta, very good illustration regarding oligohydramnios, pathophysiology and management. I have one question to the panel. A lot of times, because particularly in rural practice, we'll be missing amniocentesis in some cases, and patient will not be turning up, and ultimately they'll go into oligohydramnios and sometimes PPROM. And in that case, can we use the liquor which is leaking for the analysis, chromosomal analysis?
So Anuradha madam has to tell. This.
Anuradha madam will be the best person. Madam, please.
Yeah, madam, I think I will call Anu madam.
Madam is still not there.
But sir, when do you want this? I mean, I think chromosomal analysis should be done earlier on. I mean, I don't know, but I think infertility. I mean, these people from the Fertility Foundation will tell us. Maternal and fetal medicine will tell us better. I don't have much concept of it, but from like say at 28 weeks or 30 weeks, when it is coming out through the vagina, it is contaminated with the vaginal fluid, and therefore the maternal cells also, and hence how effective that will be in differentiating the maternal chromosomes as well as the fetal chromosomes is controversial. And then two is that again at 28, 29 weeks or say even 32 weeks, would it be effective to do a karyotyping at that stage?
Yeah. So madam, you have to answer, madam, whether they collected liquor, which is the leaking liquor. So your question is like that.
Lot of times, around 26 weeks and or so, people will come with leakage. So that in that case, whether to continue or terminate, that further decision, particularly in precious pregnancies, is there any way of using that like for chromosomal analysis?
Hello everyone. So I heard the question, sir. So the thing is, everything depends on case to case. Like if it is, as you said, a precious pregnancy, and you don't want to do an invasive procedure at that point when there is already a leak, you can collect the sample. But the thing is, you don't want to do a karyotyping, because karyotyping is a culture-based test where you are actually growing cells in the culture. And which means if you are growing cells in the culture, the bacteria that comes during the that it catches during the track while coming out will grow much faster than the actual fetal cells. So therefore, you really don't want to do karyotyping. Instead, you do what is called a cytomicroarray test. It's a DNA test. It does not require culturing. So we extract the DNA, and even if there is, there are ways in DNA technology where we can actually find out whether the maternal DNA is contaminated with the fetal DNA or not. So by ruling out maternal DNA, if we know that the DNA that has come from the fluid belongs to the fetus, then we can easily do a cytomicroarray and give you chromosomal result.
Okay, thank you. Thank you.
You're welcome.
Yeah, can we go ahead with the third session?
Yes, ma'am.
Any other chairpersons would like to?
Hello, madam. I'm Dr. Padmalata.
Yeah,
No,
yes, ma'am.
I will introduce the chairpersons.
I'm Dr. Padmalata.
Yeah. Dr. Padmalata, she is the president of Karimnagar Society. One Padmalata CV, please. So first is the Lakshmi Renuka. She is the secretary of Mahbub Nagar OBG Society. And she is the consultant gynecologist at Tejas Hospital. And Padmalata Nagumalla, she is the fertility specialist, consultant obstetrician and gynecologist at Parthasarathy Nursing Home, secretary, IMA Rajanna Sirsilla District, president IMA Rajanna Sirsilla District, 2010 and 11, present president of Karimnagar OBG Society. And third chairperson, Dr. Lakshmi Padma Priya. She did her MBBS from Gandhi Medical College and PG from Usmania Medical College. Worked as assistant professor at Government Medical College, Mahbub Nagar, and working as associate professor, Government Medical College, Mahbub Nagar. And she did IMA fellowship in infertility. And present, she is the joint secretary of Mahbub Nagar. I request now Padmalata Nagmalla to introduce our speaker, none other than MC Patel, sir.
Okay, thank you, madam. I'm Dr. Padmalata, President Karimnagar Obstetrics and Gynecological Society. Dr. MC Patel, sir, he is a consultant obstetrician and gynecologist, medical legal advisor, medical legal counselor. Can you hear me, ma'am?
Yes, you are audible.
Yes.
Okay. And he's the candidate for FOXI President Election 2026. Sir gives medical legal training and support for members, and he was a vice president for FOXI 2018, and he was a chairperson Ethics and Medical Legal Committee 2011 to 2013, and organizing secretary AICOG in the year 2017, and Honorary Secretary and State Organization of Gynecologists and Obstetricians of Gujarat, SOGOG, 2022-2025. Organizing Chairperson, MMCon and VPCon 2018. And he was a member of PCPNDT NIMC, Government of India in the year 2015, and Gujarat PNDT State Supervisory Board 2005 to 2009. And National Managing Board member, I am Indian Red Cross in the year 2019 to 2022. And he was an honorary surgeon, Red Cross Eye Bank, collected more than 1,000 eye pairs, and services in medical camps. He served in many medical camps in northeast states under Dhanvantri Seva Yatra, under NMO and Seva Bharti, organized since 23 years. Services in medical camps in Jammu and Kashmir under Dhanvantri Seva Yatra, under NMO and Seva Bharti, organized since 6 years. And he was President Lions Club in the year 1997 to 98. And he was President AICOG 2010 to 2011. And he was President IME Ahmedabad 2007 to 2008, and a National President NMO 2016 to 2018, and organizing chairperson Vivekanand NMO Con 2013.
Thank you, madam, for kind words. Let me share my screen.
Thank you so much, sir, for having you here in this webinar.
Yeah, thank you, madam. Thank you. Is it seen? Is my screen seen?
Yes,
No,
sir.
sir.
Yes.
Yes. Is it full screen? Hello.
Sir, आपका we can only see your CV, sir.
No,
Sir,
CV.
not yet full. Sir, not yet full screen.
No, it is
Full
CV.
screen. Yes, sir.
but
Full screen कर दीजिए. Yes, sir.
Then-
Otherwise,
Sir, not yet full screen.
But in my computer, it is in full screen. So I will have to stop sharing, and then again I have to do this again. Now, is it seen full screen?
Yes sir.
Yes, full screen.
Yes sir.
Yes,
अभी
sir.
आपका
Yes.
फर्स्ट CV आ रहा है. अभी फर्स्ट स्लाइड.
TV, but is it full
Yes.
screen?
Yes sir. Yes sir.
Okay, fine. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective society. And again, I will be humbly seeking your blessings to endorse my candidature for post of President Foxy election year 2026. Because my commitment is still there. Wherever you are, I will be there. Promise to reach the unreached. So I will be seeking your blessings for post of President Foxy. And just I mentioned prior also, there will be e-nomination. And in that very e-nomination, all the president and secretary will receive communication from Foxy from 7th of May. Here I have mentioned first, but today only I came to know that there is some delay. So it will be from 7th of May. You have to click that link you have received, and on that very link, it will be asked your password, which will be given to you on your registered mobile number or email ID. And when you put that password, on screen form will open. You have to click on president and you have to write only Foxy number, my Foxy number, 400100269, and form is open and you have to do nothing. All my details will be on the screen, and in last column you have to click to nominate my candidature. If this process is initiated by president, then secretary will have to endorse, and if secretary has initiated the process, then president will have to endorse. So both will have to do by their own mobile number, which are given to Foxy, or on email ID, which is given to Foxy. So this is a very simple procedure. Only 1 minute it takes. After president, you may go with nomination for other candidates also for vice president or so. But this year, there is no election in vice president post. All vice president posts are unopposed. Same way, you will receive communication to nominate chairpersons. And in that very, just I mentioned, procedure is the same. But in that very, you will have to write Dr. Radha Lakshmi Foxy membership number, and all her detail will be on screen, and you have to click last column. So it is very simple procedure this year, and it will take only hardly rather 1 minute or so. So coming to the today's topic, legal issues in amniotic fluid embolism, we are going to discuss. So from clinic to courtroom. Usually I start any of my talk with this question: is it worth discussing? Yes. Then why? Because medical litigations are increasing in number constantly and steadily, and unluckily, we gynecologists rank first. Anywhere you go, as far as medical legal consequences are concerned, whether it is civil suit, criminal cases, in government or in MCI, NMC, wherever you go, but we gynecologists are in driving seat, and ignorance of law can never be an excuse, because as soon as any law, any act, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. And we are working in this era. As such, I have searched in Google about my illness and medical treatment, etc. But I thought, let us have a second opinion from you, and so that I am here. So we are working in this era. Patients are much more dependent to Google information, and with incomplete information, they will be in trouble, and they will be trying to put us in a crew. So as far as our obstetric practice is concerned, we take utmost care of any of our patients, but we never know. Accident may happen. And when accident happens, it becomes very difficult for us to manage the situation. And amniotic fluid embolism is again such kind of accident which is beyond control of anybody. And as far as our clinical obstetric practice is concerned, we have to save patient, we have to satisfy relative, we have to save baby, and at the same time, we have to save our own cap. So let us see. This is a real happened case with our own gynecologist from Ghaziabad. Patient was admitted with labor pain. She was at good health at the time of admission, but no satisfactory progress. Cesarean section was advised. Patient and relative were reluctant to give consent. So doctor was constrained to talk with them. Either you give me consent to proceed with cesarean section, or you can shift patient to another center of your choice. And ultimately they give consent for cesarean section. Cesarean section was done. But after delivery of baby, suddenly patient developed cardiac arrest. Amniotic fluid embolism was suspected. Patient was intubated, started positive pressure respiration very immediately, and patient showed signs of partial revival. Cesarean section was completed very quickly, very fast, and relative were informed about this mishap happened and seriousness of condition. And patient was shifted in ambulance in nearby tertiary care center with positive pressure oxygen, and doctor herself accompanying the patient in the same ambulance. Patient was put on ventilatory support at tertiary care center, but ultimately she developed cerebral hypoxia and she went into vegetative form and expired during the course of treatment. So case was filed and a compensation was demanded. Case was filed before Uttar Pradesh Medical Council, Uttar Pradesh State Commission, and compensation demanded was rupees 99 lakhs. So allegation on part of relative was, we were assured about normal delivery, treated patient very casually, didn't advise any required investigation after admission. During labor, one injection was administered, so pain was stopped, and she created the situation that and we were compelled to give consent for cesarean section. So this type of allegation are very common allegation that we were explained about normal delivery, we were promised for normal delivery, and Dr. Mayday only show and he gave some injections, so pain was stopped, and ultimately we were compelled to go for consent for cesarean section. These are very common allegations nowadays in court of law. So at the time of deciding this case, before court, point in issue was there any negligence on part of treating doctor during managing labor, during cesarean section, and after this mishap happened of amniotic fluid embolism, managing that very patient. So this should have been discussed in this very case, was the inference by Honorable Court. So Uttar Pradesh Medical Council was of opinion that doctor has no procedural lapse. He has taken utmost care of that very patient in that very given situation. But ethical committee was of opinion that doctor should be deprived of practice because in hospital there were no enough facility and she should not operate till all the facilities are fulfilled. So in this particular case, inference held by the ethical committee was like this. But in state commission held doctor responsible for this, and some compensation was awarded to the patient. So in this condition, doctor preferred appeal in National Commission. And in this, at the time of this appeal in National Commission, we medical legal experts from FOXI came in picture and came at her help. And at the time of discussing in National Commission, we had a very good discussion about this case. What is amniotic fluid embolism and which are the limitations on part of treating doctor? As far as observation and inference on part of court was, in order to succeed a claim of medical negligence, 3 requirements need to be met. So there are ingredients of negligence, and National Commission was of opinion that we have to consider all those ingredients of negligence. 1, it should be of accidental nature, of misconduct on part of doctor, existence of proven damage. Due to that action, patient should have suffered some damage. But very important part was this. Action of doctor should have direct and proximate relationship with damage suffered by patient. So if these three criteria are fulfilled, then only negligence can be proved against any doctor. Host, please mute all other participants. So there is disturbance. Host, please mute everybody except me. Is host available? Any person from Corona? Is any person is available from Corona?
మళ్ళీ నెక్స్ట్ స్కానింగ్ ఉంటుంది కదా ఆ పిల్ల వెళ్ళేసరికి కలిపోయిందమ్మా ఏం
Dr. Dwaraka Devi, can you please mute yourself? Dr. Dwaraka Devi.
Yes, I think, yes, fine. So, where is Corona people? Is there anybody from Corona?
Dwaraka Devi is not a faculty, sir. I don't know her name.
But if Corona people is there, host can mute.
She appears to be unmuted. So can anybody
Bhavana, are you there?
inform her?
Sir, I will call Bhavana.
Okay. So in this particular case, at the time of discussion, inference held by the court was doctors should put in place all necessary measures as to the current scientific knowledge. What she has done to save life of patients should be taken into consideration. And in this particular case, inference held by the National Commission was doctor perform her duty with reasonable standard and as per accepted standard medical norms. And patient was appropriately referred to higher center well in time. She was resuscitated when she suffered cardiorespiratory arrest at her hospital, and then she referred that very patient to nearby higher center. She accompanying in the same ambulance with all emergency medicine, etc. And we put Williams standard textbooks references before Honorable National Commission, and we could try to convince National Commission about this amniotic fluid embolism. So we could convince that it is rare but often fatal complication of pregnancy. Onset can neither be predicted nor prevented. Infrequent, unpredictable, catastrophic complication causing cardiorespiratory collapse, virtually impossible to predict. We cannot predict in which patient amniotic fluid embolism will happen. Diagnosis must be based on a spectrum of clinical signs and symptoms and exclusion of other causes. And amniotic fluid embolism is a syndrome typically occurs during labor or soon after vaginal or cesarean delivery or during second trimester dilatation and evacuation procedure. So we could convince court about all these things. We also convince court that most cases of amniotic fluid embolism are associated with dismal maternal and fetal outcomes regardless of quality of care rendered. Whichever standard of care we offer to the patient in this given situation, but 100% guarantee cannot be given. Early recognition of amniotic fluid embolism with prompt intervention is paramount to a successful outcome, and management is resuscitative, maintaining vital signs, and treating hemodynamic and coagulopathy derangement as they occur. So, with this reference, we could prove that we had resuscitated that very patient well in time. We had tried to maintain vitals, and we had treating that patient to maintain her hemodynamic stability. And as far as coagulopathy derangement is concerned, we had sent blood samples to rule out this coagulopathy derangement. And if at all it is DIC or so, we have to manage that also. So if we can prove in court of law with our records, then this type of cases are always decided in favor of doctor. One more area we could convince team approach among obstetrician, anesthesiologist, and intensivist is necessary for successful outcome. In this case, anesthesiologist was already there and patient was shifted to tertiary care center very immediately, and intensivist also in picture as far as management is concerned. Despite early intervention, maternal and fetal mortality remains high. It is mentioned in Williams' textbook. So we could convince court that in spite of all care and caution, extraordinary care and caution, then also maternal and fetal mortality remains very high. Thus, owing to this uncertain etiology, varying symptoms, rapid onset, and high fatality rate, amniotic fluid embolism is one of the most challenging obstetric emergency leading to cardiac arrest. Cardiac arrest is a devastating event, and despite improving resuscitation practices, mortality is high, with many survivors being left with severe neurological impairment. Even if patient survived, but due to cerebral hypoxia for longer time, she may went into some neurological deficit. Hypoxic ischemic brain injury encompasses heterogeneous cascade that culminates in secondary brain injury and neurological cell death. So, however, some do make good recovery and return home to a meaningful quality of life, but these are very rare cases which come out like this. In one more case, we refer at the time of discussing this case before Honorable National Commission, one more case which was decided in Supreme Court some other time. And in that very case, Apex Court has observed as follows, that skill of medical practitioner differs from doctor to doctor. And very nature of profession is such that there may be more than one course of treatment which may be advisable for treating the patient. So when you have more options available to treat that very patient in that very given situation, you are free to choose any one of them, and you cannot be held responsible that why you had chosen that very option and why you didn't the next option. So you cannot be held responsible for the same when you choose any one option as far as treatment part is concerned. And court would be indeed slow in attributing negligence on part of doctor if he had performed his duty to the best of his ability and with due care and caution. So it simply means if you have taken utmost care of that very patient, way in which any prudent gynecologist would have taken, then you could be out of problem. And in that very case, medical opinion may differ with regard to course of action to be taken by a doctor treating a patient, but as long as doctor acts in a manner which is acceptable to medical profession and court finds that he has attended on patient with due care, skill and diligence, then and if patient still doesn't survive or suffers a permanent ailment, it will be difficult to hold doctor to be guilty of negligence. So in this particular case of Achyut Rai Khobda, Supreme Court was very clear that if doctor has taken utmost care of that very patient in that given situation, doctor cannot be held guilty of negligence. It was inference. And at the time of deciding that very case of our own gynecologist, we had put this judgment of Supreme Court before National Commission. One more case which was decided by Supreme Court, Kusum Sharma versus Batra Hospital. And in this case also, apex court was very clear. And in that very case, inference and observation on part of apex court was Consumer Protection Act should not be held around the neck of doctor to make them fearful and apprehensive of taking professional decision at crucial moment to explore possibility of reviving patient hanging between life and death. So patient should have no sword hanging about litigation in this type of case. Court was very clear. Supreme Court has very clear inference in this type of cases. Doctor in complicated cases have to take chance even if rate of survival is low. Doctor forced with emergency ordinarily tries his best to redeem patient out of his serving. So in this particular case, before National Commission, those cases decided in Supreme Court, National Commission was very clear that it was, doctor was qualified as an obstetrician and experienced one. LSCS was performed as per standard procedure, but unfortunately, patient suffered cardiac arrest due to unpredictable amniotic fluid embolism. Though immediately she was resuscitated and she was referred to tertiary care center immediately, but she suffered with cerebral hypoxia. It was not due to negligence or deficiency on part of treating doctor at the time of conducting cesarean section or at the time of managing amniotic fluid embolism. So National Commission was of view that State Commission has erred in law to hold it as a medical negligence. So it was wrong decision of State Commission to hold our gynecologist friend negligent. It was inference held by the National Commission. So based on all this discussion, National Commission was of opinion that doctor had taken her duty with due care and caution and diligence, so she cannot be held negligence for this demise in this particular case of amniotic fluid embolism. And in this case, judgment was in favor of doctor, and it has become landmark judgment because this judgment is quoted in so many cases in other cases. But whenever we are facing this type of cases, usual question we have to answer in court of law, was it preventable? So in this particular case, sorry, as far as amniotic fluid embolism is concerned, naturally we cannot prevent it because we cannot predict that in which case amniotic fluid embolism will happen. So if it cannot be prevented, then did you diagnose that amniotic fluid embolism well in time is one more question. So if we have diagnosed well in time, and very important part, did you manage way in which any prudent doctor would have managed? So if we have managed that very patient in a very efficient manner, and if we can prove it by our record, then we are out of problem in this type of situation. Naturally, every case of amniotic fluid embolism is potential threat as far as litigation is concerned, and treating serious patient could be suicide as far as litigation is concerned. And we are bombarded with so many questions when this type of cases or in any other cases something goes wrong. So why this happened? Where were you? How it happened? Why you couldn't prevent it? Who is responsible for that? There are so many questions bombarded in this type of situation. So how to do and how to prevent, how to manage this type of situation? Records are always at a rescue. So whenever you have managed this type of cases, your records should be up to date. So keep them up to date. What was done? Nothing was neglected. Given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. And one more important part, important bills are also part of your record. Say, for example, purchase of oxygen cylinder, defibrillator, ventilator, emergency instrument like ambu bag, and all emergency drugs. So you should in a position to prove that all these were with your emergency kit in your hospital, and you can prove it by purchase bill. And not only purchase of oxygen cylinder, but refilling of oxygen cylinder bill is also very important part because in this particular case, allegation on part of relative was that when he suffered heart attack, oxygen cylinder in hospital were empty, and we were saved in this particular case only due to bill of refilling of oxygen cylinder just 1 day prior of this accident happened. We could prove in court of law, and decision was in favor of doctor. So these are very small things, but very important things. Many times in this particular situation, we have to transfer patient. So it should be in time, at proper hospital, confirm availability of bed, ventilator, OT, blood, etc. at hospital where you are referring that very patient, escort patient in the same ambulance, and handing over patient to the right and proper person is very much important. And transfer document, whichever treatment you offered at your hospital, and if you could find little time to mention in a brief, you have to give all this document to the person concerned who is taking charge of that very patient then onward. So this is list of all this, which kind of document we have to give to the patient. I do not want to go into detail, but all the document which we have given to the patient party, we have to preserve one copy of that. And you have to simply visit FOXI website. Under this FOXI uniform consent, there are 30 different consent available. With 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consent. It is available in English, in Kannada, in Marathi. Gujarati version is also ready. Hindi version is also about to finish in due course. So you can download those consent and use in your day-to-day practice. And in those 30 consent, how to transfer patient is also there. So it should be available with you, because in this type of situation, you have no time to write anything, but that consent is ready, transfer document, and you have to simply get it signed by relative at the time of handing over all the records of patient to the patient party. So there is always a way. So to conclude, prompt diagnosis is a key of success in litigation. Quick resuscitation, communication and counseling, documentation and proper record keeping, in-time transfer, multi-speciality approach, always involve your professional colleague in this type of situation. It shows your concern that you have taken utmost care to save life of patient. Medical audit of your own case where things went wrong, so that we cannot end into same type of situation in future. Indemnity cover is very much must in era of CPA. So you should be covered with adequate indemnity cover and remain alert every time in practice. Otherwise, be ready to face this type of situation. Because this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many judgments in Supreme Court, in High Court, in our favor, in favor of medical fraternity. But if you do not know, and if you do not use those judgments in our favor at the time of facing medical legal cases before Honorable Court, they won't be helpful. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. Because medicine is science of uncertainty and art of probability. And problem with world is that intelligent people are full of doubts, while stupid ones are full of confidence. So we have to decide where we stand. So to conclude, if we sleep like this, take tender care of your patient, comply with the protocols in this type of situation to manage, pray Almighty God before going to sleep, and keep my visiting card below your pillow. I am always there to assist you in any given odd situation. So all the best, and all the best to me also. God bless you. Have a litigation-free medical practice. With regards, and to end with my humble appeal to endorse my candidature for post of President FOXI election year 2026. Salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you. Thank you very much.
Thank you, sir. All the best to you.
Thank you.
I request Lakshmi Renuka to give the concluding remarks regarding Patel sir elaborate talk on medico-legal allegations regarding amniotic fluid embolism. Lakshmi Renuka. Yeah.
Yes, ma'am. Respected chairperson, esteemed faculty, and dear colleagues, it's my privilege to be part of this webinar. We sincerely thank our esteemed speaker for delivering such a clear, informative, and insightful presentation. Your valuable expertise and practical insights will definitely help us enhance our patient safety and professional responsibility, sir. I also thank for the organizing committee, technical team, and all the participants for making this session successful. Thank you, sir. All the best. We are all with you, sir.
Thank you, madam. Thank you.
Thank you.
Thank you, Lakshmi Renuka.
Sir.
Monica? Monica, are you there?
So any coordinator?
Sir, I'm there, sir.
Yes, we may proceed further.
Yes, sir. Thank you, sir, for that elaborate lecture once again. We'll proceed to the next session. We have a very interesting talk, very pertinent talk for today's times on amniocentesis and genetics by Dr. Anuradha Udmudi ma'am. We have Dr. Vishnupriya ma'am, Dr. Malleshwari ma'am, and Dr. Sweetie ma'am as our chairpersons. Dr. Vishnupriya ma'am is the secretary, is the senior consultant in Obs-Gynae at Mehboob Nagar. She has a fellowship in reproductive medicine. Welcome, ma'am. Then we have with us Dr. Malleshwari Nuka ma'am. Dr. Malleshwari ma'am is the past president of the Nizamabad Obs-Gynae Society, and she has held various key positions such as Joint Secretary of the Indian Medical Association of the Nizamabad chapter and is currently the Vice President of the Nizamabad Obs and Gynecological Association. Welcome, ma'am. Next, we have with us Dr. Sweetie Anup ma'am. Dr. Sweetie Anup ma'am is a senior consultant at nursing home at Korutla. She has over 30 years of rich experience in the field of Obs-Gynae and also has been the ex-consultant at Singareni Colliery Central Government Hospital. Welcome, Sweetie ma'am. I would request Dr. Malleshwari ma'am, I think I am seeing she's there, to kindly introduce our speaker, Dr. Anuradha Udmudi ma'am.
Good evening, everyone. At the outset, I would like to thank the organizing secretary and sir. Wish you all the best for their future endeavors. And I'm about to introduce our speaker, Anuradha. She has done her PhD in human genetics with 27 years of experience, and she designed multiple novel academic and application-oriented diagnostic tests. She did her postdoctoral work and experience in USA labs, Walkman Institute, Integrated Lab Systems and Laboratory Corporation of America. She is the Young Scientist Award. She won the Young Scientist Award at Environmental Mutagen Society USA, and she had various paper publications and reputed journals, reviewer, and she is an author of medical book chapters and other higher education courses. She has delivered CME lectures, about 350 plus, delivered at state, national, and international medical conferences. She has conducted 200 plus genetic awareness programs in South India, and she has designed world's first and most comprehensive NGS-based genomic panels for infertility and recurrent pregnancy loss, presented at ACMG 2019, ISAR 2021, ASRM 2021, and other international platforms. We all welcome you, madam, for your insightful lecture. Thank you.
Thank you, Dr. Malleshwari.
Thank you.
I hope my screen is visible. And
Yes,
is it full screen? Can someone please confirm?
No, not full screen.
Okay. What are you seeing here?
We are seeing the CV, madam.
Yeah.
Yes,
So
now it has come. It has come.
it's full screen
Yes,
now?
ma'am. Yes, ma'am.
Okay. All right. Okay. So, namaste. Hello, everyone. Thank you, Dr. Radha Lakshmi ma'am and Dr. MC Patel for giving me this opportunity to share some important points on amniocentesis. I'll be happy to answer any questions after the lecture, but I thought instead of clubbing both CBS and amniocentesis as a part of prenatal diagnosis, I only stuck to amniocentesis because of this, the nature of this webinar that is today on amniotic fluid related issues. We all know that it's an ultrasound guided procedure and it's done after 15 weeks, sometimes after 16 weeks based on the volume. And around 20 to 30 ml of fluid is retrieved using 22 gauge needle, 20 to 22 gauge. And the first few milliliters of the fluid is usually disposed or discarded, especially if it is bloody in nature. I'll be talking, most of my talk is on genetics, and so any amniocentesis procedure that I would be talking about and followed up with some cases that I would like to present are all genetics based. And so therefore, I cannot go into basics right now, but I'll just try to see how the case presentations can give you an insight on a genetic diagnosis of amniotic fluids. The procedure itself is a very safe procedure, and there is around 0.5% of patients may experience miscarriage risk. However, the risk may increase if you are doing the procedure on multiple pregnancies like a twin pregnancy. Common minor issues will be present after the procedure in some patients, like cramping, a little bit of spotting or a mild leakage, but rarely you will see hemorrhage, infection, and even fetal injury. And of course, the maternal RH sensitization is very, very important. If you know that it's an anti-D RH negative mother, then anti-D immunoglobulin should be given. Usually it's given before or after the procedure, but within 72 hours. Post-procedure care must be clearly indicated and must be counseled to the patient. Rest and any kind of report, fever, bleeding, leaking fluid, these must be communicated with the doctor immediately. Genetic counseling is extremely important. All this information should be communicated. Tests to order must be clearly explained. And not just that, a written recommendation letter through genetic counseling is important before we can take up the procedure. And a written consent from the patient is required. And as per all consent forms and all the documentation, as Dr. Patel ji also was talking about, the records have to be maintained as per PNDT requirement. So let's first now look at the indications of genetic amniocentesis. Why do we have to do amniocentesis? One, of course, the most common reason is when we see high-risk prenatal screening, we go ahead and do amniocentesis. Either it can be a double marker or a quadruple marker, or it could be an NIPT test or a failed NIPT test. These are some of the prenatal screening results that will require amniocentesis. Sometimes we can also see soft markers on ultrasound, such as high NT or absent nasal bone, echogenic bowel or choroid plexus, or ASD and VSD kind of cardiac problems. All these would indicate, they're called soft markers because they are mostly aneuploidy related markers, like for trisomy 21 or other trisomies. And sometimes the ultrasound can show major abnormalities also, like skeletal dysplasia, severe brain anomalies, ONTDs, and IUGR and IUD in some cases. All these would require amniocentesis procedure to evaluate the genetic basis. Sometimes patients come to us with family history. They can have a child with aneuploidy or a child with single gene disorder like albinism, sickle cell anemia, Duchenne muscular dystrophy, etc., or their parents or relatives could be having, the parents themselves could be having the genetic problem. For example, genetic hearing loss could be, a parent could be carrying. Hemophilia, a parent could have hemophilia, or Duchenne muscular dystrophy, or recurrent, retinitis pigmentosa. There are so many disorders where the parent is affected and we need to do a procedure to find out if the fetus has the problem. Sometimes parents are normal, but they could have balanced translocations, and they are also at a risk of having a child with abnormalities. And sometimes because of the IVF, increase of IVF conceptions, and where the pre-implantation genetic testing is done on the embryos, and when the transfer is done, confirmation of those results is also done by amniocentesis. And of course, the amniotic fluid related torch is also one of the investigations that would fall under genetic amniocentesis. So with these indications, let's try to see what are the genetic tests that we need to do, that a laboratory would be doing. Now, the first test is the karyotyping test, as you all know about it. It's a culture-based test. So we are not really extracting any DNA, but we are making the cells divide. And when the cells are dividing, in their mitotic stage, we arrest them and we look at the chromosomes under the microscope. And the sensitivity of this test, I would say, what is it that you can actually see through a microscope is not less than 5 to 10 MB. So if the problem on the chromosome is around 5 to 10 MB, you will be able to visualize under the microscope and you can detect the structural variations. Of course, you can detect aneuploidy, which is the numerical abnormalities of chromosomes. Now, other than karyotyping, we can also perform on amniotic fluid cytomicroarray. Cytomicroarray, as the name indicates, is also a cytogenetic test, which is like karyotyping, which will give you a karyotype, but the technology is different. It is a DNA-based test. So if you are looking at chromosome just for aneuploidy, you can do a karyotyping. But if you want to zoom into your chromosome and look at smaller changes such as 50 kb deletions, duplications, which are all commonly called as copy number variations on your reports, this is done by cytomicroarray. So we can actually zoomed in and we are looking at small changes on the chromosomes. Here you can see that the size is 50 kb, which is much smaller than 5 to 10 MB. Now, you want to do just a single chromosome, you want to check a single chromosome, you can use FISH or you can use QF-PCR, and you can either visualize under the microscope, or QF-PCR is a DNA-based test. So these are for targeted chromosomes. And then you can actually zoom in much more and you can do what is called sequencing of the DNA. Sequencing of the DNA is basically looking at your genetic code and then seeing a change in the genetic code so that the mutation is identified and single gene genetic disorders are identified. This can be targeted where you can look at the mutation that you already know what you're looking for. But then if you do not know what you're looking for, then you have to do what is called a whole exome sequencing, which is next generation sequencing based, where multiple genes are sequenced and then a diagnosis is made. So to do all these tests, we also have another problem because the amniotic fluid is coming from, as Dr. Ashok was also asking, if we are getting the amniotic fluid, we are puncturing through the needle the maternal tissues, and it is possible that the maternal cells are contaminating the fetal sample. Now, when that happens, the maternal cell contamination, which we generally call as MCC, this can mask the fetal DNA. And when it masks the fetal DNA, we can have false negatives and false positives very rarely. And this can lead to a proper interpretation error in the laboratory, especially if it is a DNA test. If it is a karyotyping test, it's not a problem because you're growing the cells and the fetal cells grow and maternal cells get washed away. But if you are doing a DNA test, which is a cytomicroarray or a sequencing test, or a PCR test, then it is very important that we rule out that there is no contamination of maternal DNA with the fetal DNA. And what level of contamination is accepted? Around 5% of contamination is accepted. Anything beyond 5%, it's better that the lab asks for a repeat sample or wants the doctor that this could not be a accurate result. And it's done in the laboratory using several methods called DNA fingerprinting kind of method, which is done with STR analysis. And it's a very accurate method of establishing that there is no maternal cell contamination. So that is why whenever you are sending samples to a genetic laboratory, along with the fetal sample, you need to send 3 ml of mother's blood so that the maternal cell contamination is ruled out before the lab can actually take up the test. So now with that introduction, let's move on to some case presentations. The first and the most important type of cases that you will see is aneuploidy testing for cytomicroarray. In the sense, you want to see if you always have a high risk double marker or an NIPT test or sometimes a quadruple test, and then amniotic fluid comes to the laboratory. Now here, even today, people do write karyotyping, which is totally outdated. And for amniotic fluid analysis of chromosomes, you have to use what is called a cytomicroarray or a CMA test. Now, there are two types of cytomicroarrays that you can use. One is a low resolution one, and the other is a high resolution one, which is a 750K. Low resolution one is a 315K. I'm not going into details because lack of time, but the thumb rule is if you are only looking at aneuploidy, you can just use the low resolution because you are only looking at the numerical abnormalities. But if you are looking at late trimester ultrasound abnormalities, second or third trimester abnormalities, you please use a high resolution array because you are probably looking at much smaller copy number variations which have let the fetus survive up to second to third trimester instead of maybe resulting in an abortion in first trimester. So this is what is also important. Cytomicroarray turnaround time is 2 weeks. So if you have late gestation and if you are unable to wait and you need a fast result, you could also add FISH or QF-PCR to the test so that the targeted chromosome, for example, if a patient is having a high risk for trisomy 21, you could just do a FISH for trisomy 21 along with cytomicroarray. So you get a result of 21 ahead of time and cytomicroarray would confirm. Of course, never use just the FISH or QF-PCR because they are screening tests and you need to confirm it by cytomicroarray. If you look here, the comparison of karyotyping and cytomicroarray, just concentrate on the last bar where this is an abnormalities detected in karyotyping is so less compared to abnormalities on the cytomicroarray. So there is a lot of diagnostic yield in cytomicroarray and there is less amount of culture failures in cytomicroarray. Unless we are looking for some valence translocations, you don't have to use karyotyping at all. And we'll come to that a little later. Let me move ahead. Sometimes when you do cytomicroarray, you will also see that patients can reports come back saying there is what is called loss of heterozygosity. Now, what is this loss of heterozygosity? If you can see in this case, a consanguineous marriage, blood relatives, ultrasound showed echogenic bowel. 18 weeks, she's a primey. Amniocentesis was done and cytomicroarray was ordered. Cytomicroarray came out as normal, saying all the chromosomes are normal, but there is what is called loss of heterozygosity. That means if you see in this picture, you can see that the first line is one sequence and the third line is another sequence, and the third, in the middle line, there is, the line is missing. It just means that two chromosomes are showing exactly same sequence and there is no heterozygosity, meaning mother gave the same sequence, father also gave the same sequence. If both of them give same sequence, for example, in that area of sequence where the heterozygosity is missing, if there is a mutation, it is present on both the strands and that becomes a homozygous mutation which can result in recessive disorders in the baby. It is not a diagnostic test, but it will tell you that because there is loss of heterozygosity here, there is a possibility that if you may have a mutation here and it could result in an abnormality. Now, we already know that the fetus is abnormal in the sense the features are abnormal with echogenic bowel. So we wanted to make sure. So therefore, we did whole exome sequencing in this case, and we found a pathogenic RET gene variation, and we have diagnosed Hirschsprung disease. Now, Hirschsprung disease, the patients were counseled that surgical options are available, although untreated cases can be life-threatening, but the patient actually opted for MTP because they still had the time for it. And this is one of the example how loss of heterozygosity in an array report can help you do further testing so that you can offer your concrete diagnosis to your patients. Another case of consanguinity with I come from Telangana. There's a very high rate of consanguinity here. So I will be presenting another second case of consanguinity with a history of a child with albinism. Now we did whole exome sequencing for the child and we identified a mutation on TRY gene, tyrosine related gene. And we know that this is the cause for albinism. And we also know instantly that there is 25% risk for this baby to have, for this couple to have another baby with albinism. But because they were consanguineous, we cautioned them saying they could be carrying more number of mutations which are common and not just the albinism. For example, you can see in this picture, unshared people will share less number of mutations, but unrelated patients will share less number of mutations. But first cousins, they share more number of mutations. So we did carrier screening for this couple and we identified that they are also carrying another pathogenic mutation common in both wife and husband, which is retinitis pigmentosa. And that means they have 25% risk for both albinism and retinitis pigmentosa. Now, this would not have been possible 10 years back. I mean, my lab is 27 years old, and I know that we could only check for something that is indicative. But here you are preventing ahead of time. You know that the couple are at risk for two different genetic disorders. Therefore, we performed this targeted mutation analysis for albinism and retinitis pigmentosa in the next pregnancy. And albinism, the fetus was homozygous normal. And for retinitis pigmentosa, the baby was a carrier, unaffected carrier, just like parents. And CMA was normal and they delivered a normal child. This is another case of an ultrasound abnormality. You can see here that there is unilateral ventriculomegaly. Baby also had an ESD reported. This was around 20 weeks of gestation, primary again. Amniocentesis was done and cytomicroarray was sent as a first tier test for analysis. ACMG, American College of Medical Genetics, gives us quite straightforward guidelines saying that cytomicroarray is the first tier test in ultrasound abnormalities. Although now with a lot of sequencing being done, this is being debated in many scientific communities. So we did cytomicroarray in this case, and we found a pathogenic mutation on duplication on 17p at the point 11.2. P is the short arm, and this is nothing but a diagnosis of Potocki-Lopsky syndrome. Now, this syndrome will have neurodevelopmental disorders and congenital heart problems, and it's a pathogenic mutation. You can see here the blue mark here beside the chromosome. This is where the duplication is. The duplications are always represented as blue. Deletions are represented as red. And because of this is an autosomal dominant disorder, usually the recurrence risk is very, very low. However, because of the severity of the abnormal condition, they have opted for MTP. And parental karyotyping was normal. That means the recurrence risk is further less. So this is one case. And let's move on to another one, which is the Kleefstra syndrome. Kleefstra syndrome, this patient around 18 weeks, primary with elevated NT and VSD on ultrasound, NIPT was normal. So we did amniocentesis and performed cytomicroarray. Of course, as NIPT was indicated, all chromosomes were totally normal, but the Kleefstra has, there was a deletion on 9th chromosome, and you can see here, and this is the most important gene. The small deletion that I have put up here, which is 0.8 MB, covers all these genes, and so many genes have been deleted, of which the most important is the EHMT1 gene, which causes Kleefstra syndrome. And this again results in multiple abnormalities, and genetic counseling was given to them, and we told them that this is sporadic event and they don't have to worry about recurrence risk. And we did parental karyotyping and it was normal. and we assured that the risk is very, very low for future pregnancies. Another case of 19 weeks, cerebellar hypoplasia, ventriculomegaly, IUGR. We found that there is a deletion on 5th chromosome, and this is nothing but the textbook classical Cray-Duchat syndrome. 49 genes were deleted in this process of deletion, and patients have opted for MTP. Now, if the baby would have survived, the baby would have features like microcephaly, of course, the monochromatic cry, which is classical, and psychomotor and mental retardation. Genetic counseling was offered, and we told them that 90% of the cases are sporadic. However, 10% are associated with parental balance translocations. And we did karyotyping, and we found that the mother is a carrier of 8 and 15 translocation. And because the 15th translocation involved this area of the small arm of 5, it resulted in an unbalanced gamete, giving rise to deletion of chromosome 5. In these cases, the recurrence risk is around 20% because the parent is a carrier. And in subsequent pregnancy, we offered amniocentesis followed by a cytomicroarray, and the baby was normal with no deletion. So just a slide to show you that the translocations here you see actually 2 transferred to 4. These parents are totally normal because there is only a balance. Instead of me sitting here, I could be sitting at some other place, but function is same. So the exchange of material is not going to harm. But when this translocated chromosome actually forms a gamete, then you can form unbalanced gamete. So if this part of 2, which is attached to 4, goes into the gamete, you're getting an extra 2. And if this part of the deleted 2 goes into the gamete, you're getting a deleted 2. So because of this, the chances of the offspring having an abnormality goes up to 20%. But I have to remind you here that the cytomicroarray test, which is done usually on the fetuses, on the amniotic fluid, or on products of conception, will not be able to pick up balanced translocations because it's a DNA test, and because it is just looking at the amount of DNA that is present in the cell, but not the exchange of material. In karyotyping, we visualize, but in cytomicroarray, it's a DNA test. So if you are to keep it simple, if you are testing parents, please use karyotyping. But if you are testing the fetus, do a cytomicroarray, because cytomicroarray is very good at picking up unbalanced gametes, but it cannot do a balanced translocation. So let's move on to another case. So I just wanted to contradict myself here quickly, where I just said that we cannot offer cytomicroarray to parents. We should do parental karyotyping. But then there can be certain cases where we have to do a cytomicroarray in parents. And what are those cases? For example, here we have seen an IUD at 22 weeks. They have done amniocentesis. Doctor has performed amniocentesis and sent the sample to lab. MTP was followed. Cytomicroarray shows that there is a microdeletion with 43 OMIM genes deleted, but we had to classify it as a variant of uncertain significance. That means we really do not know if this deletion is associated with the phenotype, which is the IUD. Now, what we have done is we have checked both the parents, father and mother, for the same deletion. Of course, the karyotype will not be able to pick up because it's a very, very small deletion, right? So we did an array and we found that whatever deletion the fetus has, the father also has the same. So the father has the same deletion and father is totally normal phenotypically. That means this is not disease causing copy number variation. So we have determined that it is not a copy number because it's a variant of uncertain significance. We have then changed the report to benign and you had to give a normal report. So in such cases, rare cases where you want to determine the pathogenicity of a variant of uncertain significance, you will use testing parents with CMA. Otherwise, it's mostly karyotyping. This is a case of, sorry, my scrolling is, this is a case of Aniridia. Aniridia, you know, it's an absence of iris. This baby did not have iris and we found that there is a deletion of 11p in this baby, Again, 77 functional genes were deleted. And because PAX6 was deleted, she did not have iris. PAX6 is very important for iris development. And in next, it's usually sporadic, but next pregnancy patients opted for amniocentesis, but the array was normal. They delivered a normal baby. Autism is another very important, a very commonly diagnosed condition these days in our labs. Autism was mostly multifactorial, but now it's becoming more and more genetic in nature because of good technology available. The first tier test is still cytomicroarray. So you can see here, in both cases, it's a 3-year-old autism child. In the first child, we did cytomicroarray and we found a deletion on chromosome number 2. And we said, okay, this is low recurrence risk, no need to worry. There won't be a risk for future pregnancies. The second case, we did cytomicroarray, same phenotype. It was normal. There were no copy number variations. So we had to do what is called whole exome sequencing. In whole exome sequencing, we identified SHANK3 gene mutation and we diagnosed it as Phelan-McDermid syndrome. Now, the features are, of course, global development, hypotonia, etc. And both the parents were carriers for this mutation. That means because it's a recessive disorder, both the parents being carriers, the textbook explanation will be 25% risk for all future pregnancies. And therefore, we offered amniocentesis for future. This time, we simply did SHANK mutation and CMA, and both were normal. So they delivered a normal baby. Sometimes it can be an X-linked condition and parents can come with family history and family members may not be available. For example, in this case, the female's brother had Duchenne muscular dystrophy, but he expired at 21 years. So we found that there is a deletion in the mother, which is 50%. Mother usually has 2 X's, right? In one X, 50%. If you see this picture, actually, you will understand that exons 40 to 48 have been deleted 50%. So the line is at 0.5. Of these 2 chromosomes, one is deleted. If she passes on this X to the male, then male will not have a counter X from the father. Father will give a Y. Therefore, males will be affected, 50% of males. So we did amniocentesis for the next pregnancy and we found that there is a total deletion. You can see the red dots at 0. That means it's completely deleted. In mother, you can see the red dots at 0.5. In the fetus, you can see at 0. That means it's completely deleted. Obviously, it's a male child where you are giving, the mother gave the X chromosome and it's deleted and he does not have another X chromosome to cover it up. So here 50% risk for male offspring was given. In subsequent pregnancy, there was no deletion detected and they delivered a normal baby. Another reason why amniocentesis is done these days is to confirm the PGT reports. Pre-implantation genetic testing is being offered on embryos, and these embryos sometimes results come with low mosaicism. That means around 20% to 30% of cells have an abnormality, but rest of it is normal. They usually transfer these low mosaic embryos, saying they're giving a caution. But then we do not know after they go and implant into the uterus how they will develop and what will happen to the fetus. And therefore, amniocentesis is strongly recommended for such mosaic embryo transfers. Sometimes the PGT results may not be conclusive because you don't have extended family members available to do a linkage study. Even in those cases, amniocentesis is done. So let me quickly summarize. I don't want to keep you from dinner. That these are the genetic tests that amniocentesis is usually done for. One, karyotyping. You want to look at chromosomes. That's culture-based. Second, FISH and QF-PCR. You want to get quick result for some specific chromosomes. 3, cytomicroarray. This is an extremely important test for checking aneuploidy and copy number variations to detect deletion syndromes or duplication syndromes. 4, There is whole exome sequencing where you are looking at 25,000 genes, you're sequencing them because you don't know what to look for. So there is a syndromic presentation, but you do not know which gene actually is responsible. Then we do a whole exome sequencing. Then sometimes we only do targeted known mutation, fifth test, where we already have done familial studies and we know what we have to look for. Parents are carriers of thalassemia. We will only look for thalassemia mutation. Parents are carriers of albinism. We will only look for albinism mutation that we identified in the family. So targeted mutations are done for those conditions, or sometimes deletions and duplications, as I have shown you in DMD case or a spinal muscular atrophy case, we offer MLPA kind of testing. So these are all the tests that one can request for in amniotic fluid to diagnose a genetic condition. So with that, I would like to say thank you again to Dr. Radha Lakshmi ma'am and Dr. MC Patel sir, and good luck to both of you. One take-home message would be genetic counseling is extremely important. Since Patel sir also spoke about legal issues, it's always better to have a documented genetic counseling report for patients in your records. Nowadays, COVID has actually taught us to do online genetic counseling, and we do more online genetic counseling than in person. But whatever is the method of doing genetic counseling, having a report of the counselor with you in your records is very important, so that we can, always prevent medical legal issues. But either way, I am very happy to answer any questions if anybody might have. Thank you so much.
Thank you, Anu madam.
Thank you, ma'am.
So you have given a elaborate but very good lecture on amniocentesis, madam. We want to come again with you.
Thank you, ma'am. Genetics is a subject. How much ever time you give me, it's not sufficient.
Can I give my patients to your number so that you can do online counseling?
Sure, ma'am. We'll guide them. There are many people will guide them.
So thank you one and all, especially Sandhya, Ashok sir, and all the presidents, secretaries of Warangal, Karimnagar, and Mahbub Nagar, and other presidents and secretaries of Telangana for your participation, and past president and past secretaries and professors working in Telangana, and Anu Udumudi madam, especially at the last. I thank you, Ashok sir, for your participation as chairperson for almost 3 sessions.
My pleasure, madam.
And thank you for your enthusiasm, sir. And I request one and all for your support, and I request all of you to nominate MC Patel sir for the post of president and me for the chairperson, ethics and medical legal committee chairperson. I'm contesting for the second time because I'm more into academics. So being into FOXY, I can do some of the academic programs along with MC Patel sir in future during his tenure as president. So I request all of you to support both of us. Thank you, one and all.
All the best, madam. MC Patel sir, all the best. We are all with you, sir.
Thank you, sir.
Maleshwari madam, do you want to tell anything? Maleshwari madam. Maleshwari madam, you are muted, madam. Okay.
All the best, Radha.
It's very informative, right?
Thank you.
All the best, Patel sir and Radha Lakshmi madam. Both.
Thank you.
Yes. Good luck. See you soon. See you soon on the executive board.
Okay. Monica, do you want to conclude the session? Monica Gupta, are you there?
Any coordinator, Nivedita, Monica, or Satabdi, anybody?
I think they are not. So,
no issue, Radha, you can conclude.
So thank you one and all once again for your participation as speakers, chairpersons, in this elaborate webinar on amniotic fluid and its abnormalities and amniocentesis. Thank you once again, MC Patel sir and Corona Remedies people.
So thank you all.
Thank you.
Thank you, sir, MC Patel, sir, and thank you, Dr. Radhalakshmi.
Thank you.
Thank you, sir.
Thank you, Anu madam.